And my disclosures would be that I'm not a fellowship trained tumor surgeon. I have visited Tata Memorial for 3 hours, and my mentor is Dr. Dhal. I'm fortunate he's here, and we are from an era probably where structured ortho onco training did not exist. So Dr. Manish has smartly picked up my words from my latest editorial, which is going to be out on Monday. So we need to address this, that do we need to have an ortho-onco specialist for curettage in giant cell tumors? So all of you know, and you have probably seen in life that giant cell tumors, although coming under one umbrella, can have a really varied type of presentation, both regarding their site as well as their extent of involvement of that particular area. It's a very, very intriguing disease in which the global recurrence rate continued to be high over the last 1 century probably. They have dropped, but they continue to be. So are we dealing a disease within the disease? Have we understood the disease? So third recurrence, Dr. Manish showed a fourth recurrence probably. And is it the disease or the surgeon who is failing or who is winning over here? So why is it that certain giant cell tumor come as a blown out lesion? And do we really understand the pathoanatomy of the Campanachi grading? That if we leave a type 1 for X number of years, will it convert to type 3? Or are we getting hold of a few type 1s which are actually type 3 and we have got hold of them very early? So I don't think we've understood this disease since its rates of recurrence have been high. So this is what is a debate today, that should this procedure of curettage, which could be parallel to a saucerization in a osteomyelitic limb, where again probably it is important to do a similar act. So curettage of giant cell tumor should be done only by an orthopedic oncology specialist. This is what was asked from me, and my answer would be a no, no, and many other no's. The conference is itself for that. Oncology in general orthopedic practice. So the CMEs which are being conducted over the globe are to educate the masses and not take away their skills. So we are not here to boast our abilities, but we are here to give you principles, to give you insights on how to maybe make a diagnosis, how to maybe take a biopsy, and how to give maximum outcome to a patient with the very basic little simple infrastructure which Dr. Manish has shared, meaning a headlight and a high-speed burr and various other things. So if we have to break it down, our part of discussion is just on curettage, and we are not involving adjuvant and cavity filling right now. And the outcomes which we are looking at are local recurrences, the most important one, and of course the function and complications which would come with any procedure. So I see this video more often and I showed it to my residents. It's about how to do an extended curettage, and it has been done by my friend Dr. Manish. And it's an amazing video. It's really available. It's in JBJ's Essential Surgical Techniques. So what it tells us? It tells us 4 things about curettage. You need adequate exposure, you need high-speed burr, you need illumination, and you need magnification. Beyond that, you definitely need what all of you have in between your both ears. You need to be very diligent and perseverant surgeons. The act which is needed is to take away the tissue which is there, which you have seen in your imaging, which you have seen in your clinical examination. And these 4 abilities, these 4 actions can be executed by most of the orthopedic surgeons. And the other part is avoid contamination and use adjuvants judiciously. So this is the crux of the whole thing. And I think if you have to learn how to do a curettage, look at this video. And what is an orthopedic oncosurgeon? That's a big question which I was asking Dr. Maheshwari before I came up here, and probably the answer is who does only orthopedic oncology and doesn't do anything else. Because still globally also the structuring of orthopedic oncology is evolving. We still don't have MCH programs probably in our country on orthopedic oncology. It's basically the hard work of Tata Memorial, which has given so many good ortho oncosurgeons to our country. And there are other centers now who are running fellowship program like Max itself and All India Institutes. So the editorial which we were talking about also talks about the downsides and the upsides. So the market, the patient, and healthcare is unaware the turmoil which is going through in medical education today. The intern today we have is not the same intern we had 20 years back. The postgraduate who is passing out of most of the orthopedic training institutes is not the same. So you would, Dr. Manish, Dr. Akshay would feel a similar difference of the type of fellows which they receive who are 5 years post MS. So there is a difference in the training structure which is creating a havoc in this country in healthcare. And being on both the boards of super specialization as well as the basic training trembling is a very, very tricky area. So if you have to count right now, you have the GCRI Ahmedabad, AIMS Delhi, Adyar Cancer Institute, Rajiv Gandhi Cancer Institutes, which could be, institutes where regular, huge volume of work is being done on orthopedic oncology. But if you look at the training part, probably it is the Tata. It's a Tata Memorial, which is the pillar which has remained for decades together, and we are not seeing a change. So, to graduate to a scenario where every giant cell tumor which has to be curated has to be done by a orthopedic oncologist is like a big dream. If it comes to, it's great, but it might not be a possibility in today's time. And this was a great article which Akshay gave me. And it actually talks about what we are debating right now. So I had to present evidence. So it talks about the adequate surgery is more important than oncology training. The things which Dr. Manish has emphasized in his video, or surgical management by a high volume specialized teams. They have compared with surgeons less than 10 years, more than 10 years, and they have found that there are no differences. And this is a very large study, and it comes from surgeons from Japan, Turkey, and Greece. And they have also found that probably using bone cement is one of the major things which helps you reduce recurrence. You can debate, there are evidence available against that also. So we'll not talk about adjuvants, and they have a big role in recurrence, in function, and in complication. And we'll not talk about filling defects because we're talking only about curettage. So the curettage part, I'm sure, can be done by orthopedic surgeons of pretty balanced experience in their life. So this is a article which I put on purpose, which talks about the same fact that if a particular surgery is done in a center of high volume, there is a possibility that the outcomes would be higher. But does it matter in giant cell tumor where curettage is a treatment? We need to think about it. So we never settle for being the best. We always strive to be better. That's why all of us are here, to get the tips and learn about the right ways of doing curettage, to give due care when we are doing it. If you ask me, when the whole volume of the giant cell is out, after that I look at the clock and spend 45 more minutes. So that's my rough way of how I do it. So if it give due care to the four principles and the two adjunct principles, probably a balanced orthopedic surgeon can do a fair job in a giant cell tumor. So I would conclude my debate that curettage for giant cell tumor should be done only by orthopedic oncology principles. Whether it is being done by a non-orthopedic oncologist or otherwise, the principles should be stuck with, and we should be able to get good outcome. Thank you.